Hello and welcome to Chapter 9 in Electronic Health Records. We're going to be talking about managing insurance, billing, and reimbursement. And this is really one of the longest chapters in this book. So I'm probably going to break this one down into two separate lectures. Now, again, because this is such a long chapter, I'm going to let you actually read some of this information on your own. One thing I do want you to pay special attention to is on 225 at the beginning of the chapter, there's an insurance timeline there. Be familiar with those dates. You may have a question or two on tests that will come from this timeline. All right, so moving over to page 226. As with any business, to be successful, a healthcare organization must be financially stable. The financial stability of a healthcare organization results from the careful management of the health insurance, billing, and reimbursement process. In this chapter, we're going to explore the concepts of health insurance, billing, and reimbursement, and the role of the EHR in managing those transactions. Now, to understand health insurance, billing, and reimbursement, you first have to understand revenue cycle management. The Healthcare Financial Management Association, HFMA, defines the revenue cycle as all administrative and clinical functions that contribute to the capture, management, and collection of patient service revenue. The revenue cycle begins with the admission or registration of a patient and ends with collection and posting of payments. Now, figure 9.1 shows the revenue cycle management process, and this figure is over on page 227. Be familiar with this figure. So again, your first step starts at the very top of the circle, patient admission registration. It's the only block that has an arrow, and it's showing you that everything after comes from the right side. So you're moving on to verification of insurance benefits and eligibility. Then you're posting charges to the patient's account. Coding and billing happens next. You're submitting your claims to your insurance companies. Then, if any rejected claims come back, you have to actually correct and rebill those claims. And then, hopefully, you're getting paid and you're posting payments. And then, on the flip side of that, any denials that come in, you're managing your denials and appealing those. And then, you're also at the end, back end, you're monitoring your accounts receivable. Again, making sure you're being paid. So, again, be familiar with figure 9.1 on page 227. Now, these slides are just a little bit wonky as far as following along in the book. So we're going to hit the health insurance section under the at the bottom of 226, moving over to 227. So most of you are familiar with the concept of insurance. You have car insurance, you have homeowners insurance, life insurance, and then, of course, your health insurance. Now, with any type of insurance, an individual makes a specified number of consistent payments called a premium. Now, your premium goes to your insurance company in exchange for payment if something occurs. So if you have damage to a house from a storm, or you have a car wreck, or there's a death, or you get sick and have to go to the hospital, insurance is going to pay at that point because you paid your premiums. Now, the definition of health insurance is a type of insurance that pays for healthcare services that are incurred by the insured persons. Now, in our discussion of health insurance, the third-party payer is going to be the insurance company. After patient admission or registration, which we're going back up to looking at our little revenue cycle management figure here, the second step is to verify insurance benefits and eligibility. Now, we learned in Chapter 4 that admission and registration clerks are generally responsible for entering insurance information into the EHR system at the time the patient is admitted to an inpatient hospital or scheduled for treatment at an outpatient facility or a physician's office. Following insurance data entry, the registration clerk or insurance verifier must confirm with the insurance company that the patient's insurance coverage. Now, there's two purposes for this. First one, you have to ensure that the patient actually has active coverage. Anybody can flash an insurance card to you to show that they can pay or that their insurance will pay, but it may not be active. They may not actually be paying those premiums to have that coverage. Second is to determine important billing aspects of the insurance plan, such as your guarantor information, covered dependents, co-payments, deductibles, and any other limitations or payment rules. Now, moving on to page 228. I want to go through understanding the health coverage section. I want you to be sure to read through it again yourself. I'm going to read through that one section only, and then we're going to skip evolution of health insurance. I want you to read it yourself, and we're going to get over to insurance terminology on 230. So let's look at 228 first, understanding health coverage. Now, we have some scenarios here that will be beneficial for you when we start getting more deeper into these terms: subscriber, guarantor, and so on. Okay, so Samuel Elliott is a retired Army captain who saw his doctor for unexplained headaches. When we drop down into the bottom, we're going to look at what type of coverage each one of these people have. So remember, Sam Elliott, retired Army captain. Angela Singh is an unemployed single parent with 2 children. She took her children recently to their pediatrician for back-to-school checkups. Hazel Bellamy, 83-year-old widow, and she's a retired librarian, and she made an appointment for a Coumadin check at her clinic. Then we have 25-year-old Matthew Foltz, who is a full-time manager at a small family-owned company, and he was injured at work. Now, dropping down to right where you see the bolded term third-party payer. So in our group of scenarios, each individual has health coverage, but they have different third-party payers. Remember, our third-party payers are our insurance companies. Samuel Elliott, he was our retired Army captain. He has TRICARE. It's a federal program for retired military. Angela Singh, the unemployed mom with 2 children, has Medicaid, which is the state-administered health insurance program for low-income families and children. Hazel Bellamy was our 83-year-old widow who was a retired librarian, and she has Medicare. And then Matthew Foltz, he has traditional health insurance, but his mother is the subscriber through her employer. Now, we're going to move over to 230, and we'll pick up with some of this discussion here. So insurance terminology, we're going to continue on with our terms here. So it's a very difficult concept to navigate. It's important to be familiar with the different terms so that you have a better understanding of health insurance concepts. So our first term we're going to talk about is subscriber. This is the person whose insurance coverage is used for acute or outpatient care. This is the person who usually pays for the health insurance and or whose employment makes him or her eligible for enrollment in the health insurance plan. So using our individuals that we talked about, Samuel Elliott and Hazel Bellamy are the subscribers for their health insurance. Angela Singh is the subscriber for herself and her 2 children, and Matthew Foltz, his mother, is the subscriber for his health insurance, because I don't remember saying it exactly, but it does say that Matthew Foltz, his mother, is the subscriber through her employer. Now, continuing on over onto 231, the insurance premium, which our premium definition was still up here, the insurance premium is the amount that the subscriber pays to the insurance company. And again, this money is usually paid in regular installments, usually monthly, in exchange for the coverage. Coinsurance is the insured person's share of the cost of a covered healthcare service. It's calculated as a percentage of the allowed amount for the service. Now, if your coinsurance is 20%, then our example says if the plan's allowed amount for the office visit is $100 and the individual has met the deductible, then they have to pay $20 because they're paying 20% of the allowable amount. The allowable amount was $100, 20% is $20, and then your health insurance plan is going to pay the rest of the allowed amount. Your copayment is the fixed amount that an insured individual pays for a health care service, usually at the time the service is provided. So anytime you've gone to the doctor, you typically have a copay that you pay right then. Maybe $15, maybe $20. In some cases, seeing a specialist could be up to $35, maybe more. But that's the money that you're going to pay right then at the time of service. Now, the out-of-pocket amount includes expenses for medical care that are not reimbursed by the insurance company. Your out-of-pocket costs include deductibles, coinsurance, and copayments for covered services, plus all costs for services that are not covered. So think of the out-of-pocket amount as the money you are paying out of your pocket. That's why it's called that. It's coming out of your pocket. Again, deductibles, your coinsurance, your copayments, and then anything that's not covered, you're on the line for. So that's your out-of-pocket amounts. The allowed amount is the maximum amount on which payment is based for covered healthcare services. The allowed amount is how much the insurance carrier has agreed to pay for the visit and is negotiated between the insurance carrier and provider. This amount may also be referred to as eligible expense, payment allowance, or negotiated rate. If the healthcare provider charges more than the allowed amount, the insured individual may have to pay the difference. All right, let's talk about our benefit year. Benefit year is the year of insurance benefit coverage under an individual's health insurance plan. January 1st to December 31st is your typical benefit year, but some plans may have benefit years that do not align with the calendar year, and it could be April 1st to March 31st as an example. All right, let's talk about annual limits. Now, a cap on the benefits of the insurance company will pay in a year is called your annual limit. These caps are sometimes placed on particular services such as prescriptions or hospitalizations. Annual limits may be placed on the dollar amount of covered services or on the number of visits that will be covered for a particular service. After an annual limit is reached, the insured individual must pay all associated healthcare costs for the rest of the year. Now, you also have a cap on the total lifetime benefits that you can receive from an insurance company. This is your lifetime limit. An insurance company may impose a total lifetime dollar limit on benefits. Most of the time it's a $1 million cap. Or limits on specific benefits, such as $200,000 lifetime cap on organ transplants, or one gastric bypass per lifetime, or a combination of the two. After a lifetime limit is reached, then the insurance plan no longer pays for covered services. The Affordable Care Act created policies that changed the way some insurance companies handle lifetime limits. Okay, now we're getting into our guarantor. Not always the same person as the subscriber. So the guarantor is the individual responsible for payment. An example might be a man who obtains health insurance coverage through his employer for himself as well as his spouse and children. In such an example, the man is the guarantor or subscriber, and the spouse and children are covered dependents. Now, let's go back to our Matthew Fultz example. He's a 25-year-old man who has a full-time job, but he is on his mother's insurance through her work. Now, she is the subscriber, because she pays for that insurance premium each month. But again, he is a 25-year-old man with a full-time job. He will be his own guarantor because he's going to be responsible for the payment of his health care. So if he goes to the doctor, his mom is not paying for that for him just because she's the subscriber to the insurance. Now, in this situation, because he's 25 years old and he's still on his mother's insurance, he is still a covered dependent, but he is his own guarantor. If I go to the doctor, I'm the subscriber for my own insurance. I'm also the guarantor for my insurance. I'm going to be the individual responsible for payment. If I take my son to the hospital, they are on my husband's insurance. So my husband is the subscriber. However, I'm taking him to the doctor. I'm filling out all the paperwork. My husband is the subscriber, but I can be the guarantor because I will be the individual responsible for payment. So they're not always the same thing. All right, moving on to, we'll get there on the next page, but let's finish up with deductible. I think deductible was still up here somewhere in that very first slide. I told you things are a little wonky here. Now, a deductible is the amount an insured individual must pay out of pocket before the insurance will pay. This payment must be met before insurance coverage can be applied to healthcare services. For example, a family insurance plan may have a $25 copayment every time the parent takes his or her sick child to the pediatrician. That same family may have a deductible of $800 a year for healthcare services such as laboratory, x-rays, hospitalization before their insurance provider pays the remaining balance of any services rendered. Once the bill has been submitted to the insurance company, the deductible is calculated. The insurance company sends payment to the healthcare facility and sends the guarantor a copy of the explanation of benefits. The explanation of benefits details how the insurance company paid the healthcare bill. The healthcare facility subsequently bills the guarantor for the remaining balance of the bill that the insurance company did not pay. So that's how your deductible and coinsurance and all of that work. All right, moving on to classification of insurance plans. So we have our group health insurance plans and we have our individual health insurance plans. And again, a little wonky in the slides because it's backwards from the way it's listed in the book. Now, insurance plans that are individual health insurance plans are where you go out and you find your own insurance and you purchase it. You can go out on the healthcare exchange and look for an insurance coverage that works for you, or you can just go out and find something that's going to suit your needs. So that's you going out purchasing your own insurance. Really not any different than you going out and finding someone to cover your car. You might shop around and find what car insurance plan is going to work best for you. You can do the same for your health insurance. Now, group health insurance, this is insurance plans that provide healthcare coverage to a specific group of people, usually based on an employer. So here at Itawamba Community College, I have a group health insurance plan. ICC has went out and got this plan for us, and we all are covered by it. North Mississippi Medical Center, they have their own group health insurance plan. Ashley Furniture has their own group health insurance plan. So individual means, again, like car insurance. You're going out and getting your own insurance plan as an individual. Group health insurance plan typically comes through an employer. So know the difference between those two. Now, dropping down to the last section in that paragraph, it starts getting into managed care plans and how we have 3 different types. Should remember this from alternate care. So we have HMOs, we have preferred provider organizations, or our PPOs, and then we have our point of service plans, which is kind of a hybrid of a HMO and a PPO. I'm not going to read through each one of those. I want you to kind of go back through those sections yourself. So on 232, all the way up through COBRA, I want you to read through that section. That's going to cover your HMOs, your PPOs, your point of service plans, your healthcare savings accounts, and COBRA. Now, we're going to pick back up with insurance classification and your healthcare providers on 233. So insurance coverage and cost are determined on the relationship of the insurance plan and the health providers. In this regard, health providers are separated into two categories. You have in-network and out-of-network. In-network includes providers or healthcare facilities that are part of a health plan's group of providers with which it has negotiated a discount. Insured individuals usually pay less when using an in-network provider because those network providers provide services at a lower cost to the insurance companies that they have contracts with. Your out-of-network usually refers to physicians, hospitals, or other healthcare providers who are considered non-participants in the insurance plan. Depending on an individual's health insurance plan, expenses incurred from services provided by out-of-network health professionals may not be covered or may only be partially covered by the employee's insurance company or the individual's insurance company. So be sure to look at the examples that they list here for you. They give you two good examples. So be sure to read through those examples as well. Now, we're going to move over into our government-sponsored healthcare plans. And we're going to start with good old Medicare. Now, Medicare is a federal health insurance program for people who are 65 or older, or certain younger people with disabilities. It also covers people with end-stage renal disease, and it has 4 parts. Maybe familiar with these. We have Part A, Part B, Part C, and Part D. We're going to break all 4 of these down. Again, be familiar with these. Part A is going to be what we call our hospital insurance. It helps cover inpatient care in hospitals, including critical access hospitals and skilled nursing facilities, but not custodial or long-term care. It also helps cover hospice care and some home health care. Most people don't pay a premium for Part A because they or their spouses have already paid through it through their payroll taxes while working. Beneficiaries must meet certain criteria or certain conditions to receive these benefits. So anybody that's ever worked a job, they know that they have Medicare taxes coming out of their paycheck. That's why you do not pay a premium for Part A. And again, it only covers hospital visits, certain visits for skilled nursing facilities. It'll cover some hospice care and some home health care. Does not cover when you go to the doctor. If you make an appointment with your primary care physician, Part A does nothing for you. That's where we come into Part B. Part B is your medical insurance, and it helps cover doctor services and outpatient care. It also covers other medical services that Part A doesn't cover, such as physical and occupational therapists and some home health care. Part B helps pay for covered services and supplies when they're medically necessary, and most people pay a monthly premium for Part B services. So Part A is going to cover you if you get sick and have to go into the hospital. Part B is going to cover you if you have to have a visit to your physician because you've got a cold or you might need some light physical therapy. That's going to cover that, but you are paying a separate monthly premium for Part B. Now, Part C is known as Medicare Advantage or MA plans. Now, Medicare Advantage is kind of like how you hear, and some of you may not be familiar, but Medicaid, you can have Magnolia, Mississippi you can have a couple other Medicaid products They're basically Medicaid, but they are managed by another party. They're not managed through the traditional Medicaid office. Well, Medicare Advantage is kind of the same thing. It's a plan that is going to be managed by another third party. So these plans are offered through private companies approved by CMS. People who select a Medicare Advantage plan will have Part A and Part B through their Advantage plan and not CMS. So CMS has kind of given the rights to other third-party companies to manage subscribers' Medicare A and B plans. So you're contacting your Medicare Advantage plan if you have an issue, not Medicare. All right, and then we're moving on to Part D. If you're familiar with Medicare, Part D is going to cover your drugs, your subscription drugs. This is a program that helps pay for prescription drugs for Medicare beneficiaries who have a plan that includes Medicare prescription drug coverage. There are two ways to get the Medicare prescription drug coverage. Through a Medicare prescription drug plan or a Medicare Advantage plan that includes drug coverage. Both of these plans are offered by insurance companies and other private companies approved by Medicare. So A, hospital insurance, B, medical insurance. Part C is Medicare Advantage, which will cover A and B, and depending on your plan, could also cover D. And then Medicare Part D is your prescription drug coverage. So be familiar with those. All right, moving on to Medicaid. Medicaid is our state-administered health insurance program for low-income families and children, pregnant women, the elderly, people with disabilities, and in some states, other qualified adults. The federal program provides a portion of the funding for the Medicaid and sets the guidelines for the program. States also have a choice in how they design their programs, so Medicaid benefits vary state by state and may have a different name in your state. Now, one thing to remember about Medicaid is we usually say it is a state-funded program, but I want you to remember that Medicaid is also federally funded, so it's kind of one of those hybrid things because it sits there and says that federal government provides a portion of the funding for Medicaid and sets the guidelines for the program. So while Medicaid is truly a state-administered health insurance program, it is also federally funded. Okay? Now, states have that choice in how they design their program. That's why it can be different state to state. And so typically when we think of Medicare, we think federal, and when we think of Medicaid, we think of state. But just know that little caveat there that the federal government does provide a portion of Medicaid funds. All right, so moving on to our military, different types of insurance plans. So we have CHAMP VA, and then we have TRICARE. Now, due to the similarity of CHAMP VA, which is Civilian Health and Medical Program of the Department of Veterans Affairs, and the Department of Defense TRICARE program, sometimes referred to by its old name, it used to be called CHAMPUS, the two are often mistaken for each other. But CHAMP VA is a comprehensive healthcare benefits program in which the Department of Veterans Affairs shares the cost of covered health services and supplies with eligible beneficiaries. TRICARE is a Department of Defense regionally managed healthcare program for active duty and retired members of the uniformed services, their families, and survivors. So they are a little bit different. All right, moving on to our next government-sponsored healthcare program, which is going to be workers' compensation. So it's an insurance plan that employees are required to have to cover, let me go back and read that again. Workers' compensation is an insurance plan that employers are required to have to cover employees who get sick or injured on the job. Workers' compensation is managed by state governments, and rules and guidelines vary state to state. States will typically reimburse injured employees covered by workers' compensation with 4 types of payment, which include replacement benefits, healthcare treatment, mileage reimbursement, and burial and death benefits. Now, with some income replacement benefits, states categorize the lost income of injured employees in one of 4 ways. These include temporary total disability benefits, temporary partial disability benefits, permanent total disability benefits, and permanent partial disability benefits. Now, your temporary total disability benefits are paid when an employee has been injured at work and cannot perform his or her work duties. Temporary partial disability benefits are paid when an employee works in a reduced capacity but cannot work to the same extent as he or she could before his or her injury. Permanent total disability benefits are paid when the worker's injury permanently prevents the worker from returning to his or her former occupation. And permanent partial disability benefits are paid when the medical maximum improvement has been achieved and a worker may be able to work in some capacity, but the injury has caused damage for an indefinite period and he or she cannot return to his old occupation. Now, the next 4 of the 4 was the healthcare treatment. With the workers' compensation payment for healthcare treatment, the medical provider who treats the work-related injury or illness will be paid directly by the patient employer's insurance. And we talked about mileage reimbursement. Injuries at work, and they must travel to their medical appointments. So if the employee is injured at work and has to travel, then they could be reimbursed for the mileage. Then we have burial and death. Dependents of an employee who dies. Dependents of an employee who dies from a work-related illness or injury are entitled to burial and death benefits. Death benefits are used to replace a portion of the employee's lost income due to the work-related illness or injury. A surviving spouse, minor children, or other dependents of the deceased employee may be eligible to receive benefits. Death benefits are typically 75% of the employee's average weekly wages. Burial benefits may be paid to the person who paid for the deceased employee's burial expenses. All right, so moving over to 237, getting into the verification of insurance coverage and benefits. Major insurance plans have web pages for online eligibility requests to determine coverage and benefits for their subscribers. In addition, providers may choose to partner with vendors that provide online responses to queries about all major insurance plans. Medicare and Medicaid also have online eligibility databases for providers to query their patients' eligibility, benefits, and in the case of Medicare, the number of coverage days in categories such as inpatient and skilled nursing facility. The Medicare Eligibility Database application is called the HIPAA Eligibility Transaction System, or HETS. This application provides access to Medicare beneficiary eligibility data in a real-time environment. And you can kind of see what a HETS response looks like in figure 9.2. All right, moving over to the billing process. Now, again, this chapter is long, and it does have some example pages in it, so we don't have just a whole lot of actual content left, but we're going to kind of go through some of this. Not as quite in detail, so I will let you know when you need to go in and read for yourself. So, practice management is the day-to-day operations of a medical practice. An important function in a medical practice is the coding and billing for medical services rendered to patients. The billing aspect of a medical practice is intricate and includes claims processing, claims management, revenue management, and reporting. Successful practice management in today's medical practice most often uses an electronic office billing system. Electronic office billing systems are used to process insurance claims. Billing staff members also need to follow up on claims that have been billed and learn how to manage the revenue cycle. Electronic office billing systems include many practice management reports that are useful to the practice managers and owners, which we'll discuss a little bit greater later. And as you learned in Chapter 4, accurate data gathering must begin before or upon delivery of healthcare services. This typically begins at the time the patient is scheduled for a visit or treatment. Patient data, including demographics, insurance, and payment information, must be updated to ensure accurate billing and reimbursement. The method of payment, such as self-payment or insurance, must be verified and entered into the electronic health record. Now, dropping down to, and again, like I said, these slides are all wonky, so slide 18 here has our figure 9.1 for revenue cycle management, so just a little bit out of order there. Let's see. Now, getting into the electronic billing process. An EHR system may have a billing software component built in, or the EHR system may interface with a separate billing software program. EHR Navigator has billing software built directly into the EHR system, so no computer interface is necessary. This is the preferred method because potential communication problems between the EHR system and the billing software system are eliminated. The electronic superbill is an itemized form that allows charges to be captured from a patient visit. The provider selects the appropriate reason for the visit and treatment rendered. A superbill typically consists of provider information, patient demographic and insurance information, and details regarding the visit, such as the diagnosis and procedure codes. The process of entering medical codes into the billing system is called charge entry. Staff members can enter charges they are responsible for or that the provider missed during the electronic superbill entry via the Add Charges button. So I'm going to let you continue reading on through there. Now we're going to move over to the top of 241. Talk a little bit about the CMS 1500 and our UB04 forms. Now, traditionally, insurance companies were billed for services provided in a physician's office using a paper billing form called the CMS 1500. The CMS 1500 is a universal claim form accepted by Medicare, Medicaid, and most insurance payers. You can see an example there on 241. Now, HIPAA regulations require that most claims now be processed electronically by using the HIPAA X12 837 healthcare claim, typically called the 837. You hear that a lot in your billing offices or business office meetings. If they talk about an 837, they're talking about the actual electronic claim, not the paper claim, the electronic claim. Now, the 837 claim file is generated by the software and then transmitted to the appropriate insurance payers. Depending on the volume of patients treated by the practice, claims may be filed weekly or even daily. Frequent claims processing should occur to keep your cash flow steady. In an inpatient facility, the UB04, which is also known as the CMS 1450, is the paper form used to bill Medicare. It's also used for billing of institutional or hospital charges to most Medicaid state agencies. The UB04 contains pertinent information regarding the patient's insurance coverage, medical provider, services provider, and diagnosis. It also contains information that allows for the billing of outpatient services. All right, let's talk about the benefits of using an EHR for billing operations. Most EHR systems have a billing software component that may or may not be used by the healthcare organization. The decision to use the EHR's billing component depends on the sophistication of the organization's current billing software. Smaller healthcare organizations and physician practices are more likely to utilize the billing software component that comes with the EHR system that they implement. Hospitals and large physician practices are likely to already have a well-functioning billing system and may choose to interface it with the EHR system instead. An interface provides communication flow between two or more computer systems. If a healthcare organization chooses to interface the EHR system with the current billing financial system, the patient record is easily accessible, which is an advantage to the billing staff. Regardless of which approach a healthcare organization chooses, an EHR system can have a positive influence on billing operations, including improved accuracy and efficiency of procedures. Now, let's talk about the improved accuracy and the improved efficiency. The implementation of an EHR system allows for better accuracy in healthcare claims. The software can check for billing errors as well as speed up the billing process. Faster bills typically improves cash flow for a healthcare facility. Using the EHR system for billing purposes may also eliminate having to chase down papers at the end of the business day. The system allows for daily charges to be reconciled and for staff to more easily determine what services and treatments were provided. Now, the improved efficiency. No longer are patients and insurance companies provided with paper bills sent via the mail. EHR software provides electronic billing and insurance forms, accesses the internet to securely send electronic bills or reminders to patients, submits claims to insurance companies and tracks their progress, checks for billing errors, provides data analysis tools related to medical office billing and finance, and more. All of these features allow for increased efficiency of the billing cycle, resulting in fewer rejected claims and a more robust monetary flow for the healthcare practice. Alright, so our super bills, are also known as our encounter forms, is a staple of every physician office because it is a document that records the diagnosis and the treatment for each patient at each visit. The content of the super bills varies by healthcare organization and contains the common diagnosis and procedures experienced by the healthcare organization. And you can see kind of an example of that encounter form, which is kind of like a super bill. It has the information, and then they usually put their most common diagnosis and things like that, and then the physician just checks off which one the patient happens to have. So that super bill is very easy for a physician to go in and just check the things that he knows that this patient has, and sometimes the diagnosis is not on that form, and the physician may document that diagnosis at the bottom in like a little note section. Now, the content of the super bill varies, and I just mentioned that, but it does vary by healthcare organization. Your super bill for a pediatric clinic is not going to be the same as your super bill for an orthopedic clinic. They're going to have different diagnoses, and so it contains check boxes next to the diagnoses, procedures, and associated international statistical classification of diseases and related health problems, and your current procedural terminology codes that are marked by the healthcare provider. Traditionally, a super bill has been a paper document that the patient carries from the check-in desk to the examination room and to areas of testing such as the lab and radiology department. The electronic version of the super bill, found in many EHR systems for the use in physician office and outpatient setting, looks very similar to the paper super bill that physicians and staff are used to. Figure 9.8 illustrates an electronic super bill, and then figure 9.9 illustrates how charges are added to the super bill. So you see there, you have those are called E&M, Evaluation and Management Codes, the office visit new, problem focused, office visit new expanded, office visit new complex. So you see charges procedure code 99201 through 99205 in figure 9.8. Well, those are your E&M level CPT codes. And so on the right side, if you're going to edit the billing information, you're going to enter the quantity. So for this patient coming in, it was an office visit new and it was expanded. So they're putting 1 for the quantity. And then you can see at the bottom, there's 1 for office visit established, detailed, and so on. So that's how they actually modify those or create those charges for those visits. All right, we're going to move on to claim scrubbing. So at the bottom of 246, before transmission of the insurance companies, patient bills are checked for errors via a process called claim scrubbing. Claim scrubbing is the process of checking claims for errors before transmitting them to insurance companies. The number of times a claim is scrubbed before the transmission to the insurance company or other payer depends on the policies of the healthcare organization and the level of sophistication of its billing or EHR system. After performing the claim scrubbing process according to its policies and procedures, the healthcare provider then corrects any errors identified by its in-house claim scrubbing report and either transmit the claims directly to the appropriate payer or transmits the claims to a clearinghouse. A medical claims clearinghouse is a company that accepts electronic claims from healthcare providers, scrubs the claims, transmits the clean claims to the appropriate payer, and returns the claims that have errors to the healthcare provider. Clean claims are those without errors. And let me tell you, that is super important in your business office. One of the things that they typically monitor is your clean claims rate, because the faster a claim goes out the door, the faster the payment comes back into your door. So it's important to not have any errors on your claims that are going out, because again, that causes staff to have to go back and rework that claim, make corrections, and payment is not coming as timely. Alright, so we're going to move on. I'm going to let you finish reading claim scrubbing, and then we're going to move on to final billing over on 247. Following transmission of the clean claim, also known as the final bill, to the payer, the EHR system automatically updates to reflect the name of the payer, date, and the amount billed. The billing supervisor of the physician practice receives a report automatically delivered to an email address that lists the accounts that were final billed. When the review of claims is complete and the claims have been marked for final billing, the claims are electronically transmitted to payers or the clearinghouse, and patient bills are printed and mailed or emailed. Since the bills have already been reviewed and marked for final billing, they are in a holding file awaiting the electronic transfer. To accomplish this, the medical biller needs to select the Transmit Claims button in the EHR Navigator. The claims that are transferred electronically are either sent to the appropriate insurance payer or the clearinghouse. Amounts that are the patient's responsibility are either printed for posting mail or postal mailing or generated and sent via email, depending on the patient's preferences. In the EHR Navigator, this is accomplished by selecting the Patient Bills button. Okay, so we're going to stop here, and we're going to pick up with a second lecture for the rest of this chapter, because again, the rest of it is more getting into your actual reimbursement. So we're going to make that clean transition from insurance and super bills and actual billing, and then we're going to start fresh in our next lecture with actual reimbursement methodology. So be sure to read this entire chapter up to this section, because we did leave out some information. Didn't cover all of it in detail. So happy reading.